Hey class, Professor Adamson here. We've got a lot to do in a short amount of time. I've already done so many takes of this. Let's just get it done. So the video that I put up yesterday, I missed a couple things that are a part of the complete audiological evaluation. And we're going to go through one of them right now. One of them is tympanometry. But before we do that, I just want to make sure that we understand that there's a designation between subjective and objective tests when it comes to audiology. Now, subjective tests are going to be more like the ones that we did yesterday. Ones that were requiring a subject to respond to a stimulus, right? So, pure tone audiometry for air conduction, pure tone audiometry for bone conduction, and a speech audiometry, where we're doing speech reception thresholds and word recognition scores. All of those are subjective tests, meaning that we are presenting something and then expecting the patient to respond in kind, okay? Now, unlike a lot of medical testing, these are subjective tests, meaning that they're behavioral tests. We are asking the patient to respond to something. And it probably doesn't, it goes without saying that patients, for one reason or another, don't always respond the way that we want them to. And you can probably guess what some of those are. Language discordance is a big one. Just lack of understanding instructions, perhaps. Sometimes people have an axe to grind. They maybe have some reason why they're wanting to fake a hearing loss, for example. Interestingly enough, I see a lot of people wanting to fake hearing losses. Not for the reasons that you would think. At the children's hospital that I work at, I probably see about one a week. It's almost always teenagers. It's almost always, there's sort of a profile of it where it's usually teenagers, usually like pre-adolescent or right in the middle of adolescence, usually female, usually somebody that's having some sort of problem with school or his or her family. At any rate, people don't fake hearing losses for the reasons that you might think, to get money, to win settlements, to sue their employer, that sort of thing. It's usually somebody who's a teenager that's having trouble, like many of us did when we were teenagers. But at any rate, subjective tests, they're not perfect. They're giving us sort of one glance at the person's hearing acuity. We do have to make sort of an assessment when we do these subjective tests as to how valid and reliable they are. So sometimes I'll put down results of pure tone audiometry and I'll write to the ENT, interpret these results with caution because I'm not really sure if the patient understood the directions, for example. But today we're going to talk about some objective tests. The reason why we also do objective testing is we want to round out all hearing testing with stuff that doesn't require the patient's behavioral response. Objective tests are tests like MRIs, X-rays, those sorts of things, where we're basically just doing something to the body and the body responds in kind, okay? So people can't really fake objective tests because they can't really fake a body response. I suppose if they had some psychic abilities they could, but we're gonna move on from that. So one of the first objective tests that we do with all patients is what's called tympanometry. Now I'm gonna flip this around to the other side. This is a tympanometer. This is the Tymps Pro. I don't really relish doing this on myself, but I'm going to. I'm going to flip it back around. So this is me. I've got this device on my shoulder. Do you see? And we put a probe tip on it. I put the probe tip into my ear. I hear a hum of about 226 hertz. And if I can get this in just right, error leak detected, of course. And now that I'm actually on camera, I can't get this to go. I need a second person, one to hold the camera and one to get this in my ears. At any rate, if this were working, 226 probe tone goes in, 200 decapascals of pressure go in, 200 decapascals of pressure go out. Let me put it on the regular. If I maybe do it not on screening, it might work. Oh, there. Okay, good. Yay, hooray. So this is a normal tympanogram. What this is when we put a probe tone into a patient's ear and we put pressure in and then out of the patient's ear canal, there is a maximum point at which the eardrum should be a good conductor of the sound. So this point right here tells us that the eardrum is working just fine. If we would have seen a flat line here, that would mean that we have middle ear pathology. If we would have seen a negative pressure tympanogram here, that would mean that we likely have eustachian tube dysfunction, like in disequal pressure disequilibrium between the outer world and the middle ear space. If we were to see a peak here, but very small, what's called restricted, we would probably be seeing pathology either coming or going. And if we saw a peak that was really super high, what's called hypermobile, we would probably be dealing with what's called ossicular chain discontinuity, meaning that the ossicles are no longer working properly, okay? Now, there's another test that we can do on here that is objective in nature. That's called acoustic reflex. I can't spend a lot of time on it, but suffice it to say, in each ear at 500, 1,000, and 2,000 hertz, we put about 80 decibels of sound at those free frequencies into the ear. What we are looking for is an acoustic reflex where the stapedius muscle, that's a muscle that's attached to the stapes, contracts and pulls the stapes laterally so that the stapes is no longer going in and out of the oval window of the cochlea as it once did. If we see the acoustic reflex, that's indicative of hearing. That's, more or less normal. It can tell us a lot about the auditory system. If we see absent acoustic reflexes, that may be indicative of other pathologies, okay? As far as other objective tests, we have the auditory brainstem response test, which we do not have time to show you the equipment here. But auditory brainstem response test is basically telling us if the patient is able to hear at the level of the brainstem. What we do is hook the patient up to electrodes on his or her head, and then we put loud clicks into each of the ears. We are measuring to see if sound is making it to the brainstem. If we see electrical activity due to auditory input, due to acoustic input at the level of the brainstem, we know that the peripheral auditory mechanism is working just fine. Auditory brainstem response is a test that we will do on babies. Once we've identified a baby as potentially having hearing loss, we will do the ABR test to see if indeed that baby has hearing loss. But before we do auditory brainstem response tests, we do a test that's called otoacoustic emissions. Otoacoustic emissions, you might remember from the YouTube project, is sort of the essence of the newborn hearing screening. All babies born in New York State, and really at this point, all babies born in the United States, we will do a screening on the baby postpartum in the nursery. You don't have to be an audiologist to do that. You can just be a hearing technician to do that. During the height of the pandemic, I was reassigned to the Wakefield Hospital. I was doing all of the newborn hearing screenings because the regular screeners couldn't be there. OAEs tell us if the outer hair cells are working or not. So even though it's not perfect, we can do a newborn hearing screening with otoacoustic emissions, where we're putting really soft clicks into the ears. The clicks go in, and if the outer hair cells are working just fine, they will emit otoacoustic emissions, a sound back out that gets picked up by the equipment. So in other words, if we had a non-functioning ear, we would see absent otoacoustic emissions. The newborn hearing screening, though, we do get a lot of false positives, as you might guess, because those clicks that we put into the ear are so soft that any sort of fluid, like vernix, anything that's still in the ear canal on either side, that side of the eardrum, or even still in the ear canal, babies were sort of swimming for 9 months, right? So, you've ever gotten out of the pool and your ear canal is still filled up with water, and the same thing happens with babies. So those clicks can't get through. So sometimes we do get some false positives, but nevertheless, the goal is to have all babies identified by 6 months. We want to know all babies that are born with hearing loss to have them identified by 6 months of age. Basically, so that we can make recommendations in terms of rehabilitation. Do we want to do hearing aids? Do we want to raise this child as a capital D deaf baby, where they, get sort of tracked into American Sign Language and going to deaf schools? Do we want to do a cochlear implant, et cetera, et cetera? Most babies do pass the newborn hearing screening, but the babies that don't come back to the hospital for an outpatient newborn hearing rescreen. We do tympanometry on the babies to see if there's any middle ear pathology. If there's not, we'll do the OAEs again. The babies either pass or they don't. If they don't, we will bring the babies back for an auditory brainstem response test. Hook the baby up to electrodes, which, as you might guess, newborn babies don't really like that. We can sedate them if we need to past the age of 6 months or so. But prior to 6 months, you know, newborn babies will sleep through a lot as long as they're not hungry and as long as they're somewhat tired. So we will do that. And after the after the ABR test, that's when we'll know if the baby has hearing loss or not. That's usually the tough visit that we have with parents, where we have to tell a parent if their baby has hearing loss or not. And remember, the hearing losses that are congenital can be anywhere from mild to severe to profound, right? We can have babies that are even sort of borderline normal, but the ABR will be able to tell us that. Okay, so that's it for objective tests. Now, there are 2 pediatric tests that I want to go over really quickly with you. I'm going to set this up. I'm going to turn it around. With the little ones, with little kids, we obviously cannot do standard audiometry where we have to, have the child raise their hand when they hear the sound. They just can't do it. An infant can't do that, obviously. Now, what I'm going to do is I'm going to hit tone. I'm going to put it as frequency modulated, so it's a bit of a warble. I'm going to put this onto speaker, and I'm going to turn it on. I don't hear that. Let's see if we can. There we go. Oh, hopefully you can hear that. Oh, sorry, the monitor speaker wasn't on. Good, good, good. So that's 60 decibels at 2,000 hertz coming out of the right speaker. Now, when I'm doing what's called visual reinforcement audiometry, I'm going to have the baby sit in mom's lap there in the center. There's a little X on the ceiling that we have mom sit right underneath. I will present the tone and present this toy and light simultaneously, and then stop. Do it again, and then stop. We keep doing that. I don't know if you can really see, not really, rats. I'll show you the boxes over there, but you'll have to believe me that there's a box with a toy in it that lights up. We keep doing that, hoping that the child will turn and look at the sound. We will then present the sound, wait for the child to turn, and then present the reward. This is really not that different from Pavlov's dog and classical conditioning, where we are conditioning the baby to turn to what they think is the toy, but really they're turning for the sound in anticipation of the toy, okay? Now, from there, we drop the decibel level, do the same thing. Baby turns his or her head down. Baby turns his or her head. Not really sure. Maybe baby doesn't turn, so go back up. Baby turns his head, etc., etc. You get the idea. We will do that in the speaker, in the sound field. It's just there in the audio, in the soundproof booth. Most babies won't let you put headphones on them, so that's why we do it that way. Now, the disadvantage of visual reinforcement audiometry is we can get pretty good results. When it works, and it's really more of an art than the science, if anything. But the problem is we really only know about one ear at that point, if you think about it. Because if we're testing, I'm going to flip this around. This is the box. You can't really see, and I can't hold it on, but there's a little panda bear inside there that lights up and, hits his or her drum. And there's a little froggy in there. We used to have this little dog, Gus, that centered kids back. So if kids were staring at the box, waiting for the sound, we'd then make the doggy dance so that we could distract the kids. His name is Gus. Unfortunately, Gus, he's gone to the Rainbow Bridge. I think he's had his day. He needs to be fixed. I don't think Gus is going to get fixed. At any rate, the next thing we're going to talk about, I didn't finish this. With sound field testing, even if a baby has normal hearing in his left ear and is deaf in the right ear, the baby still can turn his or her head to the sound. They can localize it pretty well. And you can't really make a statement about which ear it is that might have hearing loss. So when we do VRA testing, and I tell a parent, well, I know your child is hearing well in one ear. This is this infant who's, 11 months old, I know is hearing well in one ear. And they will say, well, which ear? And I'll say, I don't know. It could be the left ear. It could be the right ear. It could be part frequencies in this ear and frequencies in that ear. But I know that your child has some semblance of normal hearing. I just don't know if it's on both sides. Until the child's old enough to allow me to put headphones on the ears to test each ear individually, I can't really make much of a statement. But from a speech language acquisition standpoint, it's not ideal, but to be able to tell a parent that this child has normal hearing in at least one ear, what do we know? We know that a child with a complete, profound unilateral hearing loss is still going to develop oral language, right? They may be a little bit delayed and they may need some speech therapy, but we know that it's not a deaf child, let's put it that way. Next thing we're going to talk about is play audiometry. Visual reinforcement audiometry is good for children up until about 2.5 years old. From there, we have to do what's called play audiometry. This is fun. I like play audiometry, but sometimes I don't either. It depends on the child. This is where children can be very difficult, as you might guess. But what we do with play audiometry is I condition the child with the help of the parent to hold some sort of toy or something at his or her ear and wait for the sound, wait for it, wait for the birdie, tweet, throw it into the bucket, okay? So I have this little toy right here. This is, I call him my monkey bear. Doesn't it look like a bear to you? I think it does, but, monkeys like bananas, so I don't know. At any rate, so tweet, throw it in the bucket. Yum. You got to make it fun for the kids. Tweet, throw it in the bucket, okay? Keep doing it until you know that the kids got the game down. Tweet, throw it in the bucket, okay? And then have them hold it at their ear, and you don't help them. You play the tone, and they throw it in on their own. And if they do it, you know that they heard the tone. Now, with that, we have to do this with the portable audiometer here. And this is where things get a little tough because I'm here at the portable running all the equipment over here. And I've got the child sitting here in the chair here. And mom or dad or grandma are sitting over there. Kids are great, but they can get distracted very easily. So this is once again a little bit where the art of audiology comes in as much as the science. Now, kids, a response is a response though, right? So I will sometimes have kids be like, tweet, and they will look at me like that. Should I throw it in? Technically that's not a response because they didn't throw the banana in, but the child wouldn't be turning and looking to you for approval if they didn't hear something, right? You've got to kind of make sure that the timing is right. When we do VRA and play audiometry too, we need to start with the most important frequencies. We are not going to go through, because we wouldn't get it, we're not going to get an entire 6 frequencies on the left ear, 6 frequencies on the right ear, air conduction, bone conduction. We're not going to get an entire audiogram. We just won't. So with the little ones, we will almost always start with 2,000 hertz. After that, we will go to 500 hertz. And if we can then go to 4,000 hertz, and then we will go to 1,000 hertz. We're trying to get information to kind of anchor the child at the frequencies most necessary for speech comprehension, for speech acquisition, right? If we know that a child's hearing well at 2,000 hertz and 500 hertz, we know that this child probably has good hearing for a broad range of sounds when it comes to speech. Whew, I'm worn out. Okay, we're going to do one last thing and then we will be done with lectures for this course. I want to talk quickly about assistive listening devices, cochlear implants, hearing aids, and Bahas. Okay, let's start in reverse, well, not quite reverse order, but let's talk about hearing aids, okay? Hearing aids, you guys did do the hearing aid project, but I just want to show you some things. This is what's called a behind-the-ear hearing aid. This is just a sample, but it sits behind the ear, as you might guess from the name, BTE. It attaches this tone hook right here, too close, to a typical ear mold that's made out of silicone, and it's custom made for that person's ear. Tube connects and hangs out behind the ear. People don't really like these hearing aids. Most of my patients, when I show them these sorts of things, are like, absolutely no way. You would think that older men wouldn't be so vain, but they are. If I were to ever show this to one of my older man patients, they would like run out the door screaming. A lot of men have a lot of vanity issues as they get older, I'm finding. Hopefully that won't be me. One of the things that patients don't really like about these is they perceive that these are very visible and a lot more indicative of hearing loss, if that makes sense. But depending on how the person wears their hair or if they wear a hat, these are actually less visible than what are called ITE hearing aids, in the ear hearing aids. This is a right one because it's got a red dot on it. Now this isn't for me, this is for somebody else. It's really gross and I'm putting it in the ear, but it's just a dummy. It goes into the ear canal. It's custom made at the factory and all the mechanics of the hearing aid are in here somewhere, okay? These end up being quite visible. People think these are so invisible, but they really aren't. They have ones that go deeper into the ear. This might be called what's called a completely in the canal hearing aid. Everybody wants these. Everybody wants hearing aids that are invisible, but not always, will insurance not always pay for those? This is a super tiny CIC. Look at how tiny this one is. Most patients, if they had their druthers, would get something this small. And I've had patients in the past, not here at Montefiore, but other places, who are actors, news anchors. I had somebody who was, I don't know, for one reason or another, sorry, people kept texting me. For one reason or another, people can't have their hearing aids seen because of their jobs. If you think about it, a professional actor can't walk around with hearing aids on the set. I mean, if the character had hearing loss or it wasn't germane to the action, that would be fine. But for the most part, that they would have to write that into the story, and most people aren't going to do that. The last type of hearing aid I want to show you is what's called either a slim tube or a receiver in the canal hearing aid. This is a slim tube. It's a very small behind the ear hearing aid, but the sound goes down this tube and goes right into the ear canal. That's usually coupled into the ear canal with some sort of dome. And this is receiver in the canal. You can see that this is a wire and the sound comes right out here. With the slim tube, the sound is coming out here, out of the receiver, and then traveling down the length of the tube. With receiver in the canal, the receiver is indeed in the canal. This is supposed to kind of sound a little bit better because the sound is coming out right next to the eardrum. Hearing aids are programmed for hearing losses. So think about it. If somebody had normal hearing throughout 1,000 hertz and then fell off to a high frequency sensory, like severely profound high frequency sensory neural loss, the hearing aids will only amplify at those high frequencies. The eardrum vibrates more because the cochlea needs more amplitude at the frequencies that are lost in order to give the auditory signal what it once had. So the brain perceives things as it once was. We just needed more sound at the frequencies necessary to give us the sense of normal speech. Now, we would never say that a hearing aid kind of gives you normal hearing. It doesn't correct your hearing the way that glasses correct your vision. They give you access to sound at approximately normal levels so that you can, have a fighting chance. Hearing aids are much, 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 much better than they used to be, but they're still not perfect. And most people, I'll be honest with you, most people, they get very discouraged with them. Hearing aids are expensive. Hearing aids take a lot of work. For hearing aids to work well, you sort of have to be using them for a long period of time. You can't wait until you have very poor hearing and just throw hearing aids on. The brain, I always say this to patients, your brain is very status quo. Your brain likes things to be the way that it thinks it's always been. Most hearing loss is so gradual over such a long period of time that the brain kind of tricks itself into thinking how the person hears with hearing loss is how it should hear. You put the hearing aids on and the brain doesn't like it. People get sounds that they normally would have had no trouble with, things like the toilet flushing or maybe the dog barking or high heels. That's a big one. People tapping, fingers tapping on the keyboard are just unbearable. Hearing and noise, though, that's the real problem. Most of my patients, even people that buy the good hearing aids, even people that are very motivated, still complain about hearing and noise. What should we talk about next? This is what's called a Baha. This is a discontinued version. It's called the Siphono. Let me turn this around. Now, on the YouTube video, you probably saw this, but with a Baha, what we do is put a titanium screw on Well, this is the siphono because it's a magnet one. But if you can imagine that that was a screw, a titanium screw coming out of the patient's head, that gets surgically implanted. We wait until what is called osseointegration happens, where the bone and the titanium sort of become intertwined with each other, much like the roots of a tree. We can then put the device on, and what a Baha does, a bone-anchored hearing aid, is it bypasses the outer and middle ear and stimulates the cochlea directly by sending vibratory energy right to the fluids and the membranes of the cochlea. In other words, if a person has a permanent conductive hearing loss and we have no way of getting the sound in through here via a hearing aid or what have you, a Baha is a good solution. Insurance pays for Bahas because they're surgically implanted. They tend to be a little less noticeable because, once this person lets their hair down, you don't see it. Bahas are good for conductive hearing losses of any shape or configuration, but they're also good for unilateral profound hearing losses. Let's say this ear was deaf, the right ear. We would put a Baha on this side, sound wave energy coming in right here on the right would vibrate the entire skull and get picked up by the cochlea on the left. This person would perceive sounds coming at them on their right-hand side, even though it was really the left cochlea hearing it. That is amazing to me. If I think about that too hard, it still amazes me. Meaning that the person sort of has localization again, a little bit of hearing in stereo, even though they have one dead ear. The last thing I want to talk about are cochlear implants, okay? This is a model that I have. This is the ear, obviously. This is a right ear. But what happens with a cochlear implant, I'm going to bring this out to a picture here that we have in the hallway. We have the implant put just underneath the skin right here. The bone is sort of, I don't know what the word is now I'm looking for. Drilled out, that's the word. We drill a space for the implant to go in here, and then we thread an electrode into the cochlea via the round window. So look, the cochlea, 2.5 turns, is now going to have an electrode in it. The outer and inner hair cells, the flesh and blood of the cochlea are now sort of replaced, I guess, by an electronic version of themselves. This allows for the auditory transduction process to go right from acoustic, where sound wave energy enters the microphone right here and then the external processor, right to electric. Remember in the other video, I talked about how we go from acoustic to mechanical to hydraulic to electric. This is going right from acoustic to electric, okay? This is a pretty good life-size model of what you might expect with the cochlear implant. It's harder to see the electrode, but you can see the internal implant right there, just beneath the skin and just on the other side of the skull there. You can see how small the cochlea is relative to pictures that you always see. Pictures of the anatomy of the cochlea always make it look very gigantic. It's not that gigantic. This is one of the cutaways of the cochlea where we're seeing the scala tympani and scala vestibuli, the organ of Corti and the scala media. But you can see the electrode goes around the 2.5 turns there at the scala tympani, okay? Now, cochlear implants are best for people who are prelingually deafened, meaning that they were born and have no hearing. Somebody who's got a congenital hearing loss, for example, they're going to do well with a cochlear implant. The reason being is that at birth, the brain still has enough plasticity that you can hear sounds of relatively, I'm dropping things left and right, that you can hear sounds different than maybe you and I would hear them, but train the brain to sort of still, kind of approximate normal, what is perceived as normal language. Kids that get implanted by age 1 tend to do very well and present as normal hearing children. It takes some work to get there, but they usually do just fine. So, nowadays, if a parent is very upset or very concerned that their child is born with a congenital hearing loss, we have ways of assisting them, of habilitating that hearing loss so that they can develop somewhat normal oral language. Cochlear implants also work very well for people who are post-lingually deafened, meaning that they had oral language, and then for one reason or another, be it autoimmune issues, be it head trauma, be it, some sort of severe infection, who knows what, they get a severe to profound sensory neural hearing loss, generally bilaterally, and we don't have any way of helping them with hearing aids. We put standard or traditional hearing aids on them, and they don't help. They don't work. Cochlear implants at that point are a good option for that patient. If you think about it, that patient knew how to speak normally. At one point, that patient heard normally. So he or she remembers, they have some auditory memory of what normal language sounds like. You put the cochlear implant on, and at first it's going to sound a little bit wonky. It's going to sound a little, but the brain miraculously sort of figures it out. Even as adults, we have enough neuroplasticity to kind of have the brain pick up enough of the parts of speech that it remembers to then approximate having a normal speech signal coming in. Now, cochlear implants do not work well for people who were prelingually deafened, learned visual language, sign language, and then as an adult decide that they want to try out a cochlear implant. They can do it, but the brain is the brain is less plastic at that point when it comes to the auditory part of the brain, where speech and hearing all are supposed to sort of connect with each other. A lot of those connections just aren't there. And it's hard for those connections to be made after a certain period of time. That's it. Class, I thank you so much. This ended up being a 30-minute video. I apologize for that. I'm going to get put onto YouTube right now. I am out of breath. I'm not a young man anymore. Thank you all very much. Just email me with questions.